So as we move into the last section of today, I'm picking up on page 219, which is about 20 articles on sort of special circumstances, blunt head trauma cases. Some of these are pretty straightforward, I think obvious things, but we'll look at the evidence behind them. And we're going to start with a pretty straightforward but an increasingly common problem, which is someone has blunt head trauma, might be minor blunt head trauma, and they're on their anticoagulated status. And obviously the number of patients who are anticoagulated with warfarin has been changing because we have the novel oral anticoagulants with Xarelto and Pranaxa and dabigatran and all of that. So we have the direct factor 2A inhibitors and the 10A inhibitors are out there. What's the data on these? And we have a couple of papers that look at it. First thing I want to do is talk about some of the problems when you're talking about minor blunt head trauma. The first problem is you got to look at the paper and ask, what did they call minor blunt head trauma? And oftentimes they start with GCS because these tend to be charted, right? If they go to a trauma center or the EMS brought them in, and they'll call minor blunt head trauma GCS 13 to 15. No one in emergency medicine thinks someone with a GCS of 13 is minor blunt head trauma. So that's a very challenged definition. I really need the chart, I need the study to be GCS 15 only if you're going to do this. We all know how lousy the GCS is, right? This chair has a Glasgow Coma score of 3. So at the low end, a Glasgow Coma score fails to differentiate between animate and inanimate objects. At the high end, we just all agreed that 13 to 15, though they're relatively high GCS scores, we've all seen people with GCS, no one in here would think a GCS 13 was anywhere close to normal. That's someone who got their bell seriously rung. And in the middle, people say, well, the GCS would help you tell to intubate someone because their GCS was 8, to which I would say, if you really needed the GCS to tell you to intubate, I recommend residency training or repeat residency training, whatever it is. Anyway, so this paper 1, for example, is GCS 13 to 15. Okay, I don't like that. So they looked at this older anticoagulated group of Canadians. It's done in Ottawa, 176 patients on warfarin. 16% had bleeds. Pretty clear. Minor blunt head trauma, you're on warfarin, they're going in the scanner. And you're probably getting the neck while you're there. You're going to do the head and neck. I'm fine with that. 5 got surgery, 2 died. That's pretty worrisome data. Abstract 2 by Nishijima at UC Davis, mean age 75, on warfarin or clopidogrel. They could not create a prediction rule. I love the honesty of these authors. So they looked to try and, can we make a prediction rule, mixing their INR with their mechanism of injury and various things. And I love it when authors do the right thing, which is say, yeah, there was no prediction rule in this data set of patients that we had. Even though they had 982 patients, there was no way to get to a decision rule here. Kind of lends support to what Jerry said earlier. Complex decision-making in medicine does not lend itself to the creation of a simple decision rule. They couldn't find one. There were 60 bleeds, 30 in the warfarin group, 30 in the clopidogrel group, out of 982 patients. So it wasn't quite 10%, but still too high to say, I'm not scanning these. So pretty standard take-home fact, they're anticoagulated, they get their bell rung, they're getting a scan. I don't think anyone in here would have serious issue with that. What about this concept? Have you ever worried about this? I got a scan on them, it was normal, they got sent home, they came back 6 days later with a subdural. How many have heard of that going down? So the delayed bleed, how real is the delayed bleed? Is the delayed bleed something that we worry about? Because what would be the answer to that would be, all right, you scan them and it was negative, hold them for 12, whatever it is, hours, scan them again. Would 12 hours even be enough? And so what we know about these delayed bleeds is, yes, they're real. They are real. They're fortunately not that common, but there's a real incidence of them. That incidence has not been well described because when you want to describe the incidence of a relatively uncommon thing, what do you need? Huge trial done in multiple settings. Those huge trials haven't been done. So that's why when you want to talk about safety of things, right? If you had a drug that had an adverse drug reaction rate of 1%, that would be incredibly high. You would still need 1,000 patients in a trial to know what the incidence was, to define that 1% incidence. That's why most drug trials cannot comment on safety. Now, the authors, paid by Big Pharma, often say there was no problems, no safety issues noted. Well, they should have also noted, but the trial was completely unpowered to find a safety issue. Because for most safety trials, you need a minimum of 5,000 patients in the trial, if you're looking for a relatively uncommon thing. All right, so delayed bleeds. We don't know the exact rate they happen because we haven't done enough large trials to figure it out, but we know they do happen. And delayed bleeds, this is kind of an important thing, happen more with warfarin than with clopidogrel or the novel anticoagulants. So it's the warfarinized, the coumadinized patients that are at greater risk for the delayed bleeds. So so you'll find them in both categories, novel oral anticoagulants and clopidogrel. If you group them together, their rate of delayed bleeds appears to be half of what the rate is for the warfarin people. So it happens more with warfarin. So we got some papers here. 3 found that as well, that the delayed bleed risk was there. They noted that initially these people got scanned and they didn't recommend a reversal agent, and then later they found some of these bleeds. In abstract 4 by Peck et al., they found that age and atrophy was more important predictor than which anticoagulation agent they were on. In other words, they argued, and this is an interesting argument, that the more atrophy and the more stretching of their bridging veins, that their anatomic risk factors might be actually more important than which anticoagulant they were on. So that's kind of an interesting thing. Miller, in abstract 5, low rate of delayed bleeds, but not 0. Therefore, they recommend monitoring and rescanning as needed. Ouch, that hurts. One of the things I've gotten to on this group, so when I see someone who's on, a novel oral anticoagulant or warfarin, and they've hit their head, I've scanned them and it's negative. My next question is, I'm not inclined to keep them in OBS overnight and rescan them. I think that's crazy talk, especially since some of these delayed bleeds aren't happening until day 4, day 5. It's not like I'm gonna admit them for 5 days to wait for a delayed bleed. That would be, especially with it being a low rate. So my next set of questions after I've done the negative head and neck is, who's watching who? Is there a family member? Is there a responsible person with you? When I hear it's a 79-year-old lady who lives alone or lives with 10 cats, can your cats bring you back to the emergency room? No. Okay, so now that one I might OBS. If they've got is there a family member we can call? Can we have someone come by? I really want to know what is the nature of that safety net for them when they go. How tattered is it? How reliable is it? Those kinds of things start becoming part of my decision making. Abstract 6 is another one that says it's not just the anticoagulant, it's the atrophy. So again, the older they are, 75 and up, 85 and up, the more they have that sort of atrophy, stretched bridging veins, those are the things that seem to put them at the delayed risk. Alcohol and blunt head trauma, is there a specific risk with that? And so this has been looked at many, many times. We have at least a dozen abstracts in the database. They're usually not specifically about head trauma, they're about trauma in general. Does alcohol worsen your trauma outcomes? And here's the answers. It seems to be a bathtub curve that cancels. What do I mean by that? In some parts of medicine, there's a bell curve. Some parts of medicine, there's a bathtub curve. Lots of places there are bathtub curves. It's kind of an unusual thing. For example, if I was to ask you, tell me about dog bites. It's a bathtub curve. There's lots and lots of minor dog bites, high shoulder of the bathtub curve, almost no dog bites in the middle of moderate severity, and then there's some hella bad dog bites where you get mauled, killed, eaten. But that's the severity distribution of dog bites. It's a bathtub curve. Most minor, not many in the middle, and if they really get you and they want to do something and you're a small child or an old person or it's 3 pit bulls, then you're on this side, you're on the dead side. So here, what we find with alcohol is a bathtub curve. You've all heard the phrase, drunks and babies, they're relaxed. They don't get hurt. And in fact, that's been shown to be, in some cases, true. When you drop a baby off a 2nd-story balcony, they did the study at Irvine, they're either fine or fucked. They either landed on their head or they didn't. When they landed on their head, they were fucked. When they didn't, they were fine. There was nothing in the middle. It wasn't like, they had multiple in-between injuries. They were either fine or badly injured. And alcohol seems to do that. On the one hand, alcohol makes you drive and do really stupid things that put you at high risk for really bad injuries. On the other hand, some of them are relaxed and don't have anything happen to them. They were ejected from a vehicle at 50 miles an hour and somehow they were fine. And that's what seems to happen. And so abstract 7 sort of asks this alcohol question. They say there was no increased risk net found in the 300 cases. There was more loss of consciousness because people get hit in the head when they're drunk. Don't remember what happened. At least the providers thought there was more loss of consciousness. Not clear whether it was. All right. The next section is pediatric blunt head trauma, most of which is minor. We're talking about pediatric minor blunt head trauma. And almost everyone in here knows these rules, which to me, they were the New Orleans rule, these other rules that were advanced out there. They just, to me, have no face validity. What do I mean by face validity? You can't tell me that just because a kid barfs, they need a head CT. I mean, last I checked, up to about age 4, pediatrics is in existence of eating things and spitting them up, whether they're hit in the head or not. They cough twice and they have post-tussive barfage. They lean over and they barf. They don't like what you gave them and they barf. They have lactose intolerance and barf. They sneeze and they barf. So to tell me that just because a kid throws up once or twice after hitting their head, they need a head CT, I just don't think that has face validity. The next thing those rules said is the kid's got a little goose egg. They got a goose egg, they need a head CT. I mean, that just can't be right, just from my own childhood. And maybe this will say too much about me, but it might be TMI, but I must have had, as a child growing up, well over 100 goose eggs. You know, if I got scanned every time there was a lump on my skull that was a hematoma, and someone said, well, that's an indication for scan, I would have been scanned. I mean, it would have been absurd how many times I would have been scanned. So I just don't believe that either of those two criteria, you got a goose egg or you yorked twice, means you need a CT. That just can't be right. Now, do I believe that if you have persistent vomiting after you got banged in the head? Oh, I think that's really important. You're persistently, for hours, absolutely, I'm scanning that kid. If they've got some huge boggy skull, sure, but you can't tell me every goose egg needs a CT. So that was sort of the baseline underlying this. So let's look at what the papers say. The first paper, A, so this is, a lot of these are PCAR network, so I love the PCAR network, right? It's the Pediatric Emergency Care Research Network, Nate Cooperman, lots of academic and some community ERs that have peds where they gather up the data, usually the methods in PCAR, and if it says PCAR on it, I don't want to paint with too broad a brush, but generally if it says PCAR on it, it's pretty reliable. The researchers, I know many of them, they're careful, smart peds people that care about it. They don't want us to overdo it. They're not these ridiculously cautious, you've got to work up every kid kind of people. These are ER people with ER sensibilities about them, not necessarily pediatrician sensibilities, ER sensibilities. So what did they find? Mechanism of injury alone, just like what was the phrase I told you? Drunks and babies. They don't get hurt, they're relaxed. Mechanism of injury alone is not that predictive of injury. So in abstract 8, 3,100 kids, 0.3%, if you scan them based on mechanism of injury alone, would have had something, 0.3%. Doesn't mean you can ignore mechanism of injury, but if you're gonna say, the only reason I'm scanning this kid is their mechanism of injury, I don't like it, that's gonna lead to a lot of unnecessary scanning. So I thought that was interesting. Abstract 9, another PCAN analysis says loss of consciousness unknown, and they really tried to parse it out, like, because how do you know if a kid lost consciousness? You give me a 3-month-old, how do I know if the kid lost consciousness? Were they sleeping? I don't know. I mean, what do you ask them? The kid, what's the kid going to tell you, right? They're 3 months old. So it's often based on witness statements whether they lost consciousness, but I was happy to find out that if you look at loss of consciousness alone, does that predict whether they have a significant head injury? No, 0.5% positive, based on loss of consciousness alone. And then vomiting alone, PCARN, 0.2%. And so I love this data because it's said all the things that I believe, which is vomiting alone can't be that important. A little goose egg alone cannot be that important. Mechanism of injury, I mean, tell me that there's something wrong with the kid that they need a scan. You can't just scan someone because they got a goose egg or you didn't like the mechanism. And that's what these papers say. Abstract 10 goes a little further, says vomiting matters. And they say, interestingly, It's not one time. Remember the original paper said 1 or 2 times the kid vomits, that mattered. This one went a little further. They said, no, the kid's got to have 3 separate now, and I don't know how you break it up. If the kid goes, is that twice or once? I just want to know how they're counting that. I want to know, is that twice or once? Because I've seen that all the time. Some people will vomit just when you look in their throat. Have you noticed that? You got to be a little careful when you go into those kids with the tongue depressor. You got to be ready. Also, when you do that tongue depressor and the kid does that thing that they do, that unique pediatric thing where they go like this, and you feel the droplets hit your eyeball, and now you know that you're going to have what they have in about 30 hours, and now the detail of your history changes completely. You turn to the mom. Did you say they were having a lot of diarrhea? Now you're actually interested in that fact. Because you're trying to figure out what you're picking up from 7-Eleven on the way home tonight when they do that thing. Anyway, so they said 3 episodes of vomiting. I'm going to assume they mean 3 genuinely separate episodes of vomiting in kids are important. 1 in adults, 3 in kids. And I can kind of go with that. That's a small study, 27 kids in it. Then we get down to the scalp hematoma, Dalhousie up in Canada in 12. They let their kids get hit, and they'll hit a lot. It's cold up there, they're fishermen and shit like that. So they had 4,000 kids in this, 0 to 16, and they said that if they have a scalp hematoma, this was a little bit high for me. I was a little worried about this. They said 4%, but they had a lot of larger hematomas because Canadians don't bring their kids to the ER for nothing out in the Maritime Provinces. Have anyone been out there? They're hardy, Maritime Provinces, sailors kind of people. Your kid gets a little goose egg, you don't bring them in. When they talk about, when you read that Dalhousie, the actual paper, they describe typical of the patients that they saw was one kid had a 6-centimeter hematoma on the front, the whole front of his skull. Yeah, no, I would scan that. And indeed, that kid had a fracture and had something. Now, the better data on the isolated scalp, the one I want, because if it was 4%, which 12 says, that's what Dalhousie says, 4% of hematomas had a positive CT, that would mean the hematoma is really, really important. But let's go down to 13, which is PCARN, large data set, isolated scalp. They had a bunch of kids with isolated scalp findings only. 0.4% of the scans were positive. In other words, 99.5% would be negative. Okay, so let's talk about that for a second. I'm glad you asked. So there are a bunch of papers that talk about this frontal and occipital thing in kids, and it's both frontal and occipital. So kids who fall, little kids who fall, they tend to fall forward or backwards. They don't fall to the side as much, and they tend to get frontal or occipital hematomas when they get them, and they tend to get, if they're going to have a fracture, they get a linear non-displaced fracture. More significant trauma, and specifically child abuse, tends to be parietal in orientation and comminuted fractures. And so there's a paper that I love, and I've talked about it kind of like, academic envy is when someone does a study that was so stupid and so easy, but immediately clinically relevant. That's when, as an academic, I can tell you, as an academic, when you read a study like that, you go, shit, why didn't I do that? That's so smart. One of my favorite ped studies of the last decade is titled, If They Don't Cruise, They Don't Bruise. And all they did was count bruises. Like, you know what cruising is, right? That's when the kid can't quite walk, and they're like this. They're like leaning on the furniture. They're like thinking, I want to eat what's in her purse. But to get there, I'm going to have to go to the coffee table, and then I'm going to have to get to the hassock. And then I can eat what's in her purse. And that's called cruising, when kids do the leaning thing. And so there's a period of time when kids don't cruise, then they start to cruise. And when they cruise, they start bruising. And so kids who cruise bruise. Where are their bruises? Forehead, occiput, knees, and elbows, chin. All their bony prominences. And again, the forehead and occiput both come into that. Those are non-abuse suspicious bruising patterns. Forehead, occiput, elbows, knees. And that paper was really simple. So if you see a kid that's not up, and they have more than one bruise, that's a kid you should work up. If that's not a kid that's cruising at home, then they shouldn't be bruising. All right, so that takes us to child abuse. Yes?
So isn't abstract 13 bleeding?
It does. It does. So, but they're pulling out the isolated scalp here only. So what they're trying to do is kids that had only a scalp finding. That's what the question is in that paper. But yes, it does run contrary. As I pointed out, what they told us way back when is that kids with any hematoma or any vomiting need to be done. And what I'm presenting to you is all the data that runs contrary to that. And I love this data because I never believed that vomiting alone or a scalp hematoma alone was that important. And so here you have it, isolated scalp among the isolated though, because remember the decision rules are both scalp and vomiting and other things, was low, very low incidence. You're right. It challenges the dogma. If this seems to run contrary to what you've been hearing, you're right. That's why I'm telling it to you. Let's talk about child abuse while we're on this topic. I like this paper 14, where they looked at things that point out that you've scanned some kid who came in looking sick, and you were wondering, is it child abuse? You know, these are the kinds of kids, maybe you've intubated them already. This is a bad case. And in the midst of this bad case, you're resuscitating this kid, you're having this thought to yourself, how'd this kid get so fucked up? Is it child abuse? I mean, what happened here? Maybe it's not adding up. And here's what they found here. If a kid with head injury has a respiratory issue at any time, apnea, difficulty breathing, things that made you intubate them. If the kid has bruises on any of these, the ear, neck, or torso, those are not the ear, again, parietal, the neck, not a bony prominence, not a place that kids bruise, or torso. Ear, neck, or torso, these are red flag bruises. If their CT, once you've obtained it, has any bilateral findings, most kids that have a bleed, a subdural or an epidural, if it's a subdural, it's usually contra-coup. If it's epidural, it's usually coup, and they have one bleed. That's what accidental injury looks like. Non-accidental injury is they got a subdural on one side and traumatic subarachnoid on the other. They got bilateral subdurals. They got any bilateral findings on the CT. That's bad. And any nonlinear fracture, we're back to the frontal injuries and the occipital injuries. Kids who fall get linear frontal or linear occipital fractures. They have any nonlinear skull fracture, that's bad. So those four things, if you did them, sensitivity of 96% for child abuse as the final. You got to ask what the gold standard. The final is the investigation here, the child abuse workup. 96% sensitivity and a specificity that's not that bad for just those four things, 43%. In this series of 124 child abuse, if you use just that little system, you would only have missed 5 out of the 124. That's pretty good. That's kind of that's clinically valuable. All right, concussion. What do we have about here? And we have 2 papers, 15 and 16. As I said earlier, symptoms last way longer from concussion than we ever gave them credit for. Now, in this paper, 15% had symptoms at 90 days. At 90 days. Wow. Abstract 16, increased symptom duration is the concussion is the second or the third one. And if they have loss of consciousness, they're more likely to have longer symptoms rather than just repetitive question. Now, abstract 17, one of my favorite topics because we're doing more MRIs of heads. We agree with that. We're doing more MRIs than ever before. That the CT is sometimes considered not enough in some of these patients, and we're doing other things. Incidentalomas. What's the most common incidentalomas in the belly? Adrenal masses actually are really common. And some of those need to be worked up. So adrenal masses in the belly. There are all kinds of incidentalomas. But in the brain, there are a lot of incidentalomas. Subarachnoid cysts, sinus abnormalities, spine abnormalities, because the high C-spine is caught in congenital absence of the posterior arch of C1 is pretty common. Congenital abnormality. There's all kinds of things up there. But I love this paper. It says, and they're trying to make a point and make it newsworthy, they say incidentalomas were found on 26% of CT scans of the head. You're like, that can't be right. I mean, what do they call an incidentaloma? So you go in there, and like they considered sinus opacification an incidentaloma. All right. So now get rid of those and tell me what the remainder is. When you got rid of those, it was 7% of CT scans had incidentalomas, which were things like cysts, non-cancer lesions, bony abnormalities, et cetera. So incidentalomas, if you believe that, is 1 in 15 CT scans. Now, many of those incidentalomas I think we safely ignore, like what's the big opening in the back? It's not an Arnold Chiari malformation, but cisterna magna. That's super common. I don't even tell patients about that. Subarachnoid cysts, if they're small, I don't even tell patients about that. So most of these are of no consequence. But some of them, by the way, 1.4% were CNS masses, in which they would include the subarachnoid cysts, were probably 2/3 of those. But that still leaves 1/3 of 1.4%, or about 0.6 or 7%, where something needs to be talked to about. So that's kind of just a reminder that incidentalomas, when we have the talk about the downstream consequences of advanced imaging, you always start with, well, there's the radiation exposure. But the part that's really a big headache for us is the incidentalomas, because now you got to tell them about it. They need referral. They often get follow-up. They often get repeat imaging. The incidentalomas are a big part of the downside of advanced imaging, and this is one of the first papers I've seen that looked at it and says that to me, if I was to boil this all down, this paper, to what's important, like who cares if you got a head CT and there was no evidence of a basilar skull fracture, but there was some mastoid air cell non-opacification that you didn't know if it was traumatic or not. I mean, I don't care about that. If there's a small subarachnoid cyst, I don't care about that. A cisterna magna, I don't care about that. So, but it just points out that probably what I would say from this is that the rate of real incidentalomas, if I was to distill this down to stuff that I feel you need to comment on and get to them, it's probably 1 or 2%, which is pretty high for real incidentalomas that need follow-up on just a head CT, 1 or 2%. What happens if you change this study from head CT to MRI? The incidentaloma rate more than doubles. That's one of the big problems with MRI. The incidentaloma rate goes really high. All right, and then we have a few other PCARN papers. Like, let me ask you a question. So you see a hemophiliac that hit their head. Are you going to scan it? Of course. Abstract 18, I don't know what's wrong with these people. I don't know what they were smoking. I don't know what country they're in. But they looked at 230 hemophiliacs with head trauma and said, it's not routinely needed in minor head trauma. Go ahead and risk it. It's just a hemophiliac. Get out of Dodge. Abstract 19 is hemophiliacs again. 97 of them with 370 visits. And there were a fair number of bleeds in there, and they had minimal symptoms. So I think that if you were to ask which of those papers, 18, which says, go ahead, roll the dice, you're at the craps table, it's just a hemophiliac, as opposed to 19, which says, what are you thinking, scan them all. I'm definitely on the 19 side. I'm scanning all the hemophiliacs with minor blood head trauma. We know that the magnitude of the coagulopathy for hemophilia, let me just ask the question, greater or less than when you're anticoagulated with warfarin? Depends on what their status is, but generally speaking, worse. So if we already reached the conclusion that we're scanning all the warfarins that with the blunt head trauma, of course you're scanning all the hemophiliacs. All right, I'm going to stop there. So there's some, like I say, not earth-shattering stuff, but I love the stuff that runs contrary to the rules. It says isolated hematoma, isolated vomiting. You know, that stuff, I never thought those rules could be right. I never thought those rules could be right. And here's Jan.